also.
Yeah, okay, ma'am.
Monica, we are live now.
Yeah. Good evening, everyone. I'm Dr. Monica. I welcome you all for today's session on behalf of Shield Healthcare. And today we are going to discuss about episode 5, Cosmetic Gynae Made Easy, Premature Ovarian Insufficiency and Anti-Aging Approach. And our speaker, Dr. Kavita Babar, and our coordinator, Dr. Poonam Mishra, ma'am. And she's an MBBS DNP OBGYN, FCG FAM, President of Indian School of Aesthetic Gynecology, and she's a Chairperson Cosmetic Gynecology, SRM SIAG. Member of Sexual Medicine Committee, Foxy India. I welcome you for today's session, and I hand over this session to you, ma'am.
Okay, yes. Thank you, Dr. Monica. Thank you, Monica, for this nice introduction. And I'm here just to welcome you all for the next webinar of, as Monica told, this is the 5th webinar of Indian School of Aesthetic Gynecology. Indian School of Aesthetic Gynecology, that is ISAG, is dedicated for creating the awareness not only among the general public, but also to hold programs to sensitize doctors, as many of our gynecologist colleagues need the trainings and hands-on programs actually regarding the aesthetic gynecology and regenerative medicine. You know, regenerative medicine is the future, and today's topic, this premature ovarian failure or ovarian insufficiency, these all are actually something which actually depict that the patient is having some sort of some need for regenerative medicine, and for the recaptivating their youth and vitality. So we are going to hold our next training program on maybe the date is to come on 6th and 7th probably, for the aesthetic medicine training, aesthetic gynecology training, and the details will be following soon. And I am feeling honored to introduce our speaker, Dr. Kavita Bapat, ma'am. She's from Indore, and madam is a dynamic academician. She doesn't need any actually introduction. She's our would-be president. She's contesting, and we have to support her. And yes, all our best wishes are there with you, ma'am, and we hope to see you soon in the Fogsy's topmost position.
Thank you so much.
And
her waste time. We'll not waste time. We will teach people more because people learn.
थोड़ा सा मैम आपके बारे में बताना है कि मैम का Learn Simply group on WhatsApp is doing wonders, and she dedicatedly is teaching obs and gynae in a very crisp and concise form, and like me also have actually stored each and every format and every presentation of yours, ma'am. That is so helpful. And she's a famous vaginal surgeon also, a skill which is being forgotten. And in the new generation, this is the lap generation, you know, is now focusing more on lap, and vaginal surgeries are actually being forgotten and not being focused that much. In my opinion, actually the no-hole surgery is the best thing rather than the keyhole surgery, you know, the lap surgery. So wherever we can do something without creating any hole from vaginal surgeries, we can win many situations. So there we should avoid for going even for laps.
Thank you so much, Poonam.
So ma'am, inviting you on the dais, the board is on yours.
Thank you so much. I'll take 20 minutes. Poonam, I'll take 20 to 22 minutes. We won't spend time. If any question is answered, people can put it on the chat box so that we can answer the questions. And I'm really happy today that being a friend of you people, Poonam, Vidya Didi, those that there, and this association which you have made, I really admire the way it is, and it's really the future, as you said. It's really is going to be the future of the obstetricians, and other people will like to work more and more things into this. And the topic is really very well connected. This is premature ovarian insufficiency. I'm telling you, this topic is really the multi-faceted, multi-speciality, it includes many more things, right from obstetrician, gynecologist. It includes from the radiologists, the oncologists, the adolescent gynecists, the menopausal consultants, the infertility consultant, the geriatric consultants, so many things are involved in this subject, and the topic is premature ovarian insufficiency. Probably I have spoken on this subject many times, but always I like this subject because I have started a registry on this subject and anti-aging with premature ovarian insufficiency, because we want to teach a premature ovarian insufficiency in such a manner that we can prevent anti-aging, and it's connected to the aesthetic gynae nowadays. So it's synonymous or interchangeable: premature ovarian failure, premature ovarian insufficiency, premature menopause. Now, how to define that the premature ovarian insufficiency is the cessation of menstruation in women under the age of 40? What we'll see: elevated serum FSH levels more than 25, and in two separate occasions, at least 1 month apart, the patient will have amenorrhea as also for the last 4 months, and concomitant low estradiol. It's less than 50 picogram per ml. So make it a point: two things, elevated FSH level and a low estradiol levels, and amenorrhea at least 4 months. So FSH more than 40, clinical hallmarks: sustained amenorrhea, infertility, hot flushes, vaginal atrophy. Just give me a second. The third important point with this is age, less than 40 years. Number of primordial follicles, accelerated atresia, impaired follicular function that has decreased, estrogen less than 50, and FSH again more than 40. So if these things are all there, we claim and blame. I'm sorry for that. Now, what is the incidence? Incidence in the form of years, and the incidence. At the age of 20, it is 1 in 10,000. At the age of 30, it is 1 in 1,000. At the age of 35, in 1 in 250. And for my surprise, every one woman is having a premature ovarian insufficiency in 100 females. So it's an incidence wise. You can say it's a very popular and it's a very common disorder which we are facing. Now we say why? Why this happens? There are two things, either primary or a secondary. Primary, they can be having the chromosomal anomalies, a Turner syndrome, Fragile X syndrome. They can have the autoimmune disease, for example, the hypothyroidism. They can have Addison's myasthenia gravis, enzyme deficiency, galactose 17 alpha hydroxylase deficiency. It can happen to secondary, and the secondary is the most common one is because of the chemotherapy, radiotherapy, infections, most common in country of ours, like a tuberculosis, mumps, malaria, and varicella are the reasons for the secondary primary ovarian insufficiency. So the chemotherapy and a radiation exposure and the risk of premature ovarian insufficiency, just I was going through and I'm really happy to know about it, that the chemotherapeutic agents and a radiation dose at the age of exposure. These two things are very important when we talk about the premature ovarian insufficiency. These are the agents, chemotherapeutic agents, which causes premature ovarian insufficiency. Number 1, nitrogen mustard, chlorambucil, cyclophosphamide, busulfan, melphalan, and D-carbazine. And radiation and dose and at the age of exposure. For example, if the young girl at birth or the newborn at the birth, if she is having the radiation exposure by 20.3, she will have premature ovarian insufficiency. At the age of 10, if the radiation dose is 18.4 gyros, then she can have. Same at 20, 16.5, 14.3, and at the age of 40 or more, only 6 gyros can lead to premature ovarian insufficiency. These are other chemotherapeutic agents. They are anthracycline, that's a doxorubicin, are there. And there is a substitute hydrazine, that's a procarbazine, is one of the cause or as a chemotherapeutic agent and leading to. But how it works? Because the follicle dysfunction or the follicle depletion, the two things will happen. If there is a follicle dysfunction, follicle remains in the ovary and a pathological process prevents its normal function. So FSH receptor mutation can happen. And sometimes the follicle depletion means no primordial follicles in the ovary, failure of establishment of adequate initial pool of primordial follicle in the uterine life. And sometimes there is an accelerated expenditure of the follicles. This normally happens with autoimmune or toxic destruction of the follicle. So two things are very, very important. Again, one, either the follicles are not working properly, or if follicles are there, but they are depleting fast. So there are chances of leading to premature ovarian insufficiency. Now, just to make it a point, these are cases which comes to our OPDs and we treat them, and very, very important. Is a 28 years old presented in OPD with a headache, hypertension, casually inquiring why she had hypertension at this young age. Sonography revealed a huge ovarian cyst causing a bilateral hydronephrosis and hydroureter. Left ovary could not be visualized specific separately. CA 125 was 60. Married life 7 years but never conceived. CT scan confirmed huge chocolate cysts. Counseling was done on fertility and recurrence aspects, and laparotomy was done. Case 1. There is an imprint cytology confirmed the abscess of malignant cells, bilateral cysts removed, almost negligible healthy appearing ovarian tissues, had scanty menses for 1 year, but later she had PM of, this is a premature ovarian insufficiency, menopause for last 3 years, willing for the donor eggs, and husband semen parameters are normal. How to proceed further? This type of disease, anti-aging, is not only the aging by the face or the skin or the bone or anything, but there are several things which comes with the anti-aging things. Now this type of case. Now this is the second case. 34 years old, presented with a secondary infertility, no menses for last 10 months, scanty irregular menses since menarche, last natural conception and delivery 5 years back, hormonal assays reveal premature ovarian failure. Are these patients candidates for oocyte freezing? What can be done to delay the premature ovarian failure in these cases? And should we advise the pregnancy with the donor eggs? And what else can be tried for self-egg retrievals? Again, this is another case. 3 patient having 6 IVF failure with self-stimulation, all failed. No, now 37 years old, having no menses for last 2 years. Can repeat stimulation cycle lead to premature ovarian failure? This is a question. If what precaution should be taken in the stimulation cycles and prevent premature ovarian failure, and what are the alarming findings in IVF cycles which can suggest premature ovarian failure? So in these 3 cases, there are the variety of cases. The most one, the concerned about either hypertension because of the mass, number 2, because of the infertility, this donor egg, the freezing egg, what we watched in the failed IVF. Now these are the clinical presentation we have. Plot many, all the list is there. With a premature ovarian failure, menstrual abnormalities, missed cycles, primary amenorrhea, sudden onset of secondary amenorrhea, subfertility, menopausal symptoms, changes in the skin pigmentation, vitiligo, hyperpigmentation, adrenal insufficiency, hair loss, goiter, fatigue, anxiety, and depression. Now, these are the diagnostic consideration in evaluation, laboratory test, and arrhythmias. SCG, follicle stimulating hormone, anti-Mullerian hormone, karyotyping, fragile X, mental retardation. 1. FMR1 permutation is very important and it should be tested. Thyroid stimulating hormone, peroxidase antibody, and 21 hydroxylase antibody, and radiological test and ultrasound. SCG and dual energy X-ray absorptiometry. SCG, we have to exclude the pregnancy. FSH, it assesses the hypothalamic pituitary ovarian axis. AMH, it assesses the ovarian reserve. Karyotyping and the FMR permutation, it's evaluate the genetic etiology. Thyroid stimulating hormones and peroxidase antibody evaluate the thyroid function and quantify the risk for thyroid and adrenal dysfunction. Transvaginal ultrasound evaluate the antral follicle count and assess the ovarian reserve, and dual energy absorptiometry assess the bone density. So these are very, very important. Now, why we are worrying and we talk about the anti-aging and what are the sequels of POI. See, there are more chances. It's a way we should treat it, more genitourinary symptoms. So all the aesthetic gynecology roles comes when the there is a reduced BMD, increased fracture risk, reduced fertility, poor quality of life. See, if there is a genitourinary symptom, there is a dryness of vagina, so many things are there. The quality of the life and this will be more increased cardiovascular risk. And these patients are having high mortality rate in comparison to other patients. Now, how to manage this type of patients? Either we'll treat with the menopausal symptoms or a cardiovascular health. If infections are there, that should be treated. Now, the most important concern about, again, anti-aging, we should talk about the bone health, the emotional health, infertility, cognition are very, very important. For all the menopausal symptoms, systemic estrogen replacement, local estrogen replacement, and testosterone supplementation. Cardiovascular health, another important point, estrogen has a beneficial effect on cholesterol metabolism. It lessening the atherosclerotic plaque formation. It prevents the coronary constriction, and early initiation of the hormone therapy following the onset of menopause has been suggested as a cardioprotective strategy. So patient who is having the premature ovarian failure, giving estrogen will help her in preventing, it will be a cardioprotective strategy. For the bone health, again, fracture risk is later in life. Risk can be mitigated with the use of hormone therapy. That's another important point. But how to do it? Serial monitoring of the bone mass within 2 to 5 years of initiating hormone therapy is warranted until recommended the age of 65. Bone health, again, we all talk about anti-aging and everything. We talk about the lifestyle modification, weight-bearing exercises, dietary, avoidance of cigarette, consideration for the use of non-hormonal anti-resorptive agents, and the fracture risk reduction are there. Cognition, this is another important point. If I'll start feeling myself old, I'll think that all these are very important problems, and the rapid cognitive decline, strategies to minimize the neurocognitive disorders, and logical benchmark to guide use of hormone therapy until the age of natural menopause. Premature ovarian insufficiency is the only condition where hormone therapy or the menopause MHT or the HT is the only answer. So we cannot say these are the side effects of hormone, these are the things, but until the age of natural menopause, these patients should be given hormone therapy to prevent her aging, to prevent her bones, to protect her heart, and to protect everything, urogenital symptoms and everything. So emotional health is also important, and that's a psychological counseling, multidisciplinary team to provide continued observation, coping strategies, and to address the unmet needs. Infertility. I think infertility is also important with this. Up to 25% spontaneously ovulate, 5 to 10% will conceive, and no interventions can then reliably improve the residual ovarian reserve. Once the ovarian reserve has gone down, there is no intervention can help them. Use of donor egg, which can improve the conception rate, and contraceptive strategies should be recommended if they don't want a pregnancy. So the risk of HRT, so all the time we talk about this HRT is a problem, HRT, but the gradual and versus. Because if in the premature ovarian insufficiency, the menopause is sudden. And when we gradually be having the menopause, the problems are different and not been found to increase risk of the breast cancer before the age of natural menopause. So HRT can be given. The breast is a worrisome problem, and progestrogens should be given in combination with estrogen therapy to protect endometrium if the uterus is intact. Now the hormone treatment. What are the goals of therapy? Is to mimic endogenous level of hormones, which equates the serum E2 level of about 100 picogram once initiated. Hormone therapy should be continued until the age of natural menopause. Average age 51 years up to 47 to 51 years. These are the ages which being talked about. INFERTILITY guidelines for the management of this is a similar that either we'll prevent the follicular depletion or premature ovarian insufficiency by giving the medicines HRT are there. But what are the risks of HRT? It's found that I think this is the repeat slide, sorry for that, and the options of HRT. The number one option for HRT or the HT hormone therapy is 17-beta estradiol preferred to ethinyl estradiol or a conjugated equine estrogen for estrogen replacement. So make it a point, 17-beta estradiol is the answer. Patient preference route, method, administration of each component of HRT must be considered when prescribing as and it can act as a contraceptive needs also. Now, once we have started the HT, our responsibility is to how to monitor the HRT. The therapy with the POI and we are supposed to do should be clinically reviewed annually. Attention to the compliance. No routine monitoring tests are required, but may be prompted by specific symptoms and concerns. If there is some problem, get the test done. Otherwise, everything is normal, nothing to worry about. Sometimes we give the androgens also, and it should be evaluated. If the androgens are given, it should be evaluated 3 to 4 months. If possibly limited up to 24 months. Estrogen therapy, we can continue it for long, but if we are giving the androgens, we should be possibly limited to 24 months. Then POI and special issues with the Turner syndrome. Girls and women with the POI with the Turner syndrome should offer HRT throughout the normal lifespan. BRCA gene mutation of the breast cancer, HRT is generally contraindicated in breast cancer survivors. HRT in the treatment options of women carrying BRCA2, 1 and 2 mutations, but without personal history of the breast cancer after prophylactic salpingo-ovarectomy. So these are basically the algorithms which we should do when we do the POI patient comes to us, and it's not that tough. I'm just looking this slide very, very big and important, but I'm just making it simple. Make a clinical examination by history and examination. Initial investigation, FSH and estradiol. FSH more than 25 in 2 occasions of 4 weeks. So it's a evaluate for POI confirmed. Next, evaluate with the pregnancy, hyperprolactinemia, low BMI, eating disorder, excessive exercise. Then, if there is exposure of chemotherapy, it's a iatrogenic POI, and if there is no, then the spontaneous POI. If the spontaneous POI there is a karyotype testing are very important. If it's normal, we should go for the FMR permutation testing, and karyotyping abnormal, so it can be Turner syndrome or other chromosomal abnormalities. For fMRI permutation techniques, if it's abnormal, and a baseline autoimmune screening should also be done. So idiopathic POI consider investigation that cause clinically indicated and possible immunotherapy. Then we have to treat the anti-adrenal antibodies. We have to exclude the Addison's disease, thyroid antibodies, positively collect and refer the specialist for the celiac disease also. There are few conditions with patient have the POI and endometriosis. Women with endometriosis who require oophorectomy, combined estrogen progesterone therapy can be effective for the treatment of vasomotor, might reduce the risk of disease reactivation. So these are the basically hormone therapy in POI. Vasomotor symptom, yes. Genitourinary symptom, yes. Bone health system, health, yes. Cardiovascular, yes. Sexual function, yes. Life expectancy is another question mark. Quality of life, we have to improve the quality of life, not only by the hormone, but doing various aesthetic vaginal root surgery, reconstructive surgeries, energetic surgeries, laser, what all the new treatment modalities with anti-aging things are done. Neurological function is another important point. So the summary is like vast majority of cases remain idiopathic, short-term and lifelong implication for the health, timely initiation of the hormone therapy, multidisciplinary approach. Thank you so much for the patient listening and given me chance today to speak on the subject of my choice. Thank you so much. Thank you so much. Hi.
So very crisp and concise, just like your deliberations in cases of non-simply. Yes, ma'am. A very nice and elaborate presentation. Yeah, it was elaborate yet very crisp. So, Mr. Suman or Dr. Mayuri, are there questions?
Yes, ma'am.
Mm-hmm.
Ma'am, the one question is there, how long we can consider MHT to treat, ma'am? Like what is the duration?
As I've told you initially, that it's just like if somebody is having a fever, we give the crocin, am I right? And similarly, if the patient is having premature ovarian insufficiency, if she is less than 40 years of age, her FSH is more, estradiol is less, we have to start the hormone therapy. And we should continue the hormones. If, for example, if she is 40, and we consider our natural menopause age is 47, for next 7 years, she has to take the hormone therapy. So up to the natural age of menopause, the hormone therapy should be taken for the premature and menopausal patients.
Ma'am, one more question.
Yeah.
And ma'am, do we have a non-hormonal therapy to treat poor ovarian reserve?
Non-hormonal therapy for the ovarian reserve, there are two things in the infertilities. Number one, she should be offered the ovum donation, donor eggs. But sometimes the stem cells and the new ovary, the implantation of the ovarian tissue implantation is another new features of this. PRP has got its role, but still it's not FDA approved. It's not approved properly in our country. So it's a question mark. Can be given PRPs into the ovarian tissue, and sometimes the AMH and the depletion and the follicular these things are more, but still it's a big question mark. So best treatment for them is for if their patients are infertility, donor eggs, freezing the embryos, and they can have the babies for the infertility. But otherwise, for the stimulating the ovary, there are non-hormonal drugs. They have talked about DHEA and many more things about to promote the ovary, but they don't. We need a lot much research on it. I think Poonam will add some points on it. What do you suggest, Poonam? Other than hormonal therapy, what are the treatment points? I don't think there is any.
Yeah, for anti-aging, like these days we are considering this PRP, the very primitive one, and stem cells, adipose stem cells or bone marrow stem cells we are harvesting, and we are injecting into the ovaries and subendometrially we are going. So this is also giving one of the best results. So we can, that is why we were, a lot of work has to be
done.
Yeah. So we cannot say that this is the best option and this is the final option, but yes, future is there. We can come up with many protocols.
And for all your vaginal atrophy, for the genitourinary problems, all the aesthetic gynecology, reconstructive surgeries, which all new things are coming, that can be added advantage to them. But for ovarian reserve to come back normal, I think the hormone therapy is one of the choice, but still it only prevents the bone, heart, and the brain and the cognitive functions only. It doesn't revert back the FSH level. Maybe we read the FSH level goes down, but still the ovaries doesn't start walking the way it should be, I think. I think a lot much research is needed over it.
Ma'am, we have only 2 questions, ma'am.
Thank you so much.
Okay,
Thank you, Poonam. Thank you so much, Poonam, for giving me the chance. I always enjoy it.
Ma'am, we are honored to have you. Ma'am, we are honored to have you here.
We love you for this. Thank you.
Thank you for sparing your precious time. Bye-bye.
Thank you. Bye, Poonam. Bye.